Okay, great. Good afternoon, good morning, or good evening, depending on wherever you are. Welcome to our June session of the LabCoP. And we are delighted to have you today. My name is Anafi Mataka from the African Society for Laboratory Medicine. And as usual, I'm delighted to be your host for today's session. An important session indeed that comes after a historic occasion in the world. Today, we want to talk about the recent resolution that has been passed at the World Health Assembly on strengthening diagnostics capacity. This was officially passed on the 26th of May. Initiated by the Kingdom of Eswatini and co-sponsored by the rest of the Afro region member states, and as well as other states like Indonesia, Bangladesh, Germany, France, Canada, amongst others. This is historic in the sense that it is actually the first that addresses and urges member states to take a number of steps to strengthen diagnostics, and calls specifically on certain steps that the Director General of the WHO should take. And to do this, we are honored to have the key architects of the Lancet Commission in the name of Horton and Ken Fleming, who will discuss what they hope to see happen following the resolution. So it's really taking this from the resolution to action. And they will touch quite a number of elements that are important, such as the International Alliance for Diagnostics, how we can promote national diagnostic strategies, the use of the NEDLs, National Essential Diagnostic Lists, how can we localize production of diagnostics, including many other key elements such as data collection and how accessible and affordable these diagnostics should be. Colleagues, again, this is going to be a 1 hour long session made up of the first presentation to be made in about 20 to 30 minutes, followed by a Q&A. And as usual, put your questions and comments into the chat, and we shall take them after the presentation. A kind reminder that we do have language interpretation, simultaneous language interpretation, French and English. All you need to do is to choose the language of your choice. Just make sure you choose either English or French or Portuguese, and you should be fine. Dr. Sue and Ken, we're glad to have you here, and I would like to hand over to you for today's presentation.
Okay, many thanks indeed. I'm Ken Fleming. I'm the chair of the Lancet Commission, and it's a great pleasure to have the chance to talk to you and your colleagues today about the resolution. What we're going to try and focus on, the resolution, as we all know, is just a piece of paper. And really the key thing is now how the implementation of the various components of the resolution are acting. And since quite a number of them are going to rely on action at national level, it's really quite useful for us to have the chance to talk to you today and get some feedback from colleagues about what they think can and cannot be done and how best it might be done in terms of implementation. How we're going to do this, Sue and I are going to do a bit of a song and dance. Sue's going to do 2 or 3 slides and talk to the issues highlighted in those. She'll then stop and hand over to me, and I'll do the same and hand back to Sue. And that way we'll get through the various components of the resolution. And as I say, hope to do that in about 20 to 30 minutes, and then have a chance to get your feedback on that. So I'm going to finish my initial introduction and hand you over now to Professor Sue Horton.
Sorry, the slides are not wanting to advance here. There we go. Okay, thank you so much for inviting us to talk about the resolution. Merci beaucoup de nous inviter, de présenter les résultats ici, et nous serons heureux de recevoir vos commentaires. So when we're talking about the commission and the resolution, it's such a big resolution with 31 different steps, 15 of which relate to the member states and 16 to the World Health Organization, that I thought it was helpful to put it into this framework, which is a well-known framework that's been used for health products. So the four big characteristics of health products should be that they're available, that they are accessible, and by accessible, it means physical access, affordable, and information about them should be accessible. They should be of high quality, including safe, and acceptable to the users. So I'm going to use that framework to break this down a little bit. So as Nafi had said, the commission was proposed by the Kingdom of Eswatini, and this would not have gone forward without the enormous support from the sub-Saharan African countries, the members of Afro region, in addition to support from other countries. And you can see a draft of the full resolution. I've given the link here. So breaking down using the categorization that I suggested, firstly, the resolution does not talk about acceptability of diagnostics. I think there's a broad consensus that acceptability often means even things like self-testing or self-sampling. And the resolution does not say anything about that, but clearly that's also an important component. So just to start with the overarching elements, it calls on member states to develop a national strategy for diagnostics. This doesn't have to be necessarily a separate plan for diagnostics. It could be a component of the national health strategy, but it's a step that's been missing for many countries. And even in countries which have a strategy, often there has been no financing attached to the strategy. And many of you will know Pascal Andoa and her colleagues' work reviewing which countries have a strategy and which ones do not, and which ones have funded it. From the perspective of World Health Organization, as an organization which does a lot of coordination, there are 6 different steps called for to provide better information for member states on diagnostics. With regard to the other 3 goals from the framework, firstly, diagnostics have to be available. And in the Lancet Commission, our data suggested that almost half of the world's population had little to no access to diagnostics. They might have access to HIV tests and malaria RDTs, but they did not typically find important tests like blood glucose available, at their primary healthcare center within ready reach of them. And the situation in sub-Saharan Africa and the low-income countries was even worse, where probably less than 20% of the population have ready access to diagnostics. Ken has mentioned localization of production and technology transfer, and there are 5 steps in the resolution addressing this topic, and they're in this one special step on availability to deal with the needs of conflict situations where people do not have access to, going back to receive results of tests. So tests need to be done on the spot, and methods for transmitting results quickly need to be available. And in those situations, you have to provide tests that don't need complicated lab equipment, maybe don't even need electricity or air conditioning, because those things are not necessarily available. Safety is obviously really important. You're all lab experts, and so I'm sure you're well aware of the importance of this, both for the in vitro side as well as for imaging. And for the in vivo tests, including imaging, it's especially important because you are directly doing tests on the patient, not simply on a sample that's been provided by the patient. Okay, and lastly, affordability. We found not enough data on affordability of diagnostics, but what data was available, for example, for diabetes, suggested that it's an obstacle, that even in countries where, for example, cancer treatment might be covered under national health insurance, diagnostics aren't necessarily covered. So only the wealthier households can afford to pay for the diagnostics in order to access subsidized treatment. Okay, I'm passing it to Ken here.
Okay, thanks very much, Sue. One of our key recommendations from the Commission and picked up in the resolution is that as part of the National Plan for Diagnostics, it should address the provision of diagnostics in two aspects, basically, within an integrated tiered network of laboratories or diagnostic facilities, and that we should have a primary healthcare focus. And I think you're all very familiar with what an integrated tiered network would look like. Primary care down at the bottom here, primary health centre, largely point of care testing, and that's certainly going to be a big feature of diagnostics developments in the future and providing access and provision. It needs to move out of hospitals. It needs to become accessible in the community and even in patients' own home. And so, for instance, one of the things we identified would be point of care ultrasound should be at a health centre, for instance, for antenatal care. And then laboratory tests and microscopy. And then, of course, at the next level, more sophisticated investigations available like X-ray, automated chemistry, microscopy, and so on. And then lastly, the third layer would be the referral hospital with the more sophisticated tests, yet again, like MR. As I say, I think we're all pretty familiar with that type of model. So that's really the one of the key components of the diagnostic system, and it should be integrated, which allows, for instance, aspects to do with workforce planning, with training, with provision of reagents, equipment maintenance, and so on, can be done across the network rather than individually by separate labs and so on. Could I have the next slide, I think, Sue? One of the key components of the resolution, and again from the Lancet Commission's report, was that workforce was a huge problem, a very large shortfall. And clearly you can have all the equipment in the world, but without trained people to deal with it, it's not going to be useful. And we made some estimates of the shortfall here, getting on for 1 million people, have roughly slightly more in path and lab medicine and slightly under half in medical imaging. One thing I will say, it's unrealistic for countries, not just low and middle income countries, even high income countries, to fill this gap with training the likes of myself. It takes far too long, it's too expensive, and it's just unrealistic. So clearly new approaches were going to be needed, and we've listed some of them, which might be useful here. It'd be really interesting to get your views as part of the feedback about what you think, how best we approach the shortfall in workforce. One or two things which perhaps technology might help with, in, for instance, in providing decision support systems powered by AI, which will help people not only to use equipment, but also perhaps to give provisional interpretation, which can be then used. And of course, internet links where possible, so that not only primary or secondary opinion could be available. And lastly, just on this slide, one of the things that came across loud and clear from many people we talked to is that we need sustained continuing professional development for all of the folks involved in provision of diagnostics. There's a huge gap, and countries, when they're planning their diagnostics, should certainly look to this to make sure that people can stay up to date. Next slide, please, Sue.
Okay, so as you might expect, the COVID-19 experience led to a lot of calls for localization of production, because people realized the risks involved if you had to rely on other countries to supply, tests, treatment, vaccines. So there are no less than 4 steps in the resolution urging member states to use the existing provisions within the agreements under the WTO, the World Trade Organization, to promote joint development, technology transfer, using the TRIPS language and the Doha Declaration on Public Health, which allows for use of intellectual property if it's important for a public health emergency. But this also requires investment in local R&D and local production. And I would say that Africa CDC has been a leader in this, establishing, for example, in Senegal, facilities for developing vaccines and for diagnostics, and in South Africa for developing vaccines. So clearly this is an important need that's felt throughout the African continent. Similarly, WHO is called upon in the resolution to assist with technology transfer and local production. And I mentioned already the special needs of conflict situations. And conflict situations may need tests that are different than those on the essential diagnostics list of the WHO. You know, it may require different versions of tests that can be undertaken in very resource limited situations. As I said, no air conditioning, no electricity, maybe not even running water, and also where the results are delivered to the patient in a very timely way. Ken.
Okay, thanks, Lou. Just touching on regulation for quality and safety. Again, this came out very clearly as a major problem that lots of countries don't really have an effective regulatory system to look at the provision of equipment or diagnostics at all. And so one of the areas that again needs to be looked at is how do we provide accreditation processes, for instance, in path and lab medicine, external quality assurance systems, and how can this best be done? Can it be done best at a regional level? We are sharing resources, sharing experience, rather than particularly at national level. And again, it'd be interesting to get thoughts back on that. Imaging is a slightly different process for regulation of quality and safety. It's not so much on the actual lab or the institution, but looks at more particularly the individuals and how they go about their job. But again, there's a systematic review of processes and standards, and that can be a part of any regulatory process. Again, professional certification, competence, continuing professional development, as I mentioned earlier, it's clear that that should be part of any regulatory oversight. And the last point here I just want to pick up is about regulation of the import and use of diagnostics. When we talked to and had a workshop with manufacturers a couple of times, this became across as a very big factor for them, that having to deal with each country having its own regulation about what types of diagnostics are allowed in and what requirements are, it was extremely complicated for them to deal with. And so moving towards, again, perhaps harmonization or some sort of regional basis for regulation of import and use would be a big help. And I think would help to reduce costs and make things more affordable. Next slide, please. Again, one of the things which came across and which we've, I think you're all going to be familiar with, the WHO Essential Diagnostics List. Both the Commission recommended and it comes across in the resolution is that countries should look at how they might provide a variant of an Essential Diagnostics List. Quite a number of countries already have something similar in place presently, perhaps needs to be more systematized. This is just one example from WHO EDL first, which was published in 2018. I think we're now in a fourth version of that. And on the left, you hear this is broken by, in this case, by disease-specific in vitro diagnostics for primary healthcare localization, as opposed to more sophisticated labs, hepatitis B, hepatitis C. It looks at the tests and the purpose and so on. And there's a whole lot of work being done by the Essential Diagnostics Group at the WHO on revising these and adding to them each year. And it's there for countries to look at and perhaps adopt what is best for their particular situation. So I think we see actually putting in place an essential diagnostics list and implementing it is actually one of the key steps in terms of providing diagnostics generally. Next, to Sue.
Yeah. So in order to prioritize, other things that member states can do is to choose those diagnostics that they think are the most essential, and then put those on either national diagnostics lists, such as a national EDL, or as part of the diagnostics that can be reimbursed under national health insurance. And by choosing the things that are the most cost effective and address best the biggest domestic health needs, it's a way of focusing the limited resources on the highest priority items. So one way that can be done to help that is that member states can use health technology assessment. So I'm a health economist, so obviously I think this is an important step. And another step is to make links between the two silos within WHO. So on the one hand, we have the essential in vitro diagnostics list, which has been, I think is going into its 4th or even maybe 5th iteration now, and is quite well known. WHO also does have priority lists for medical devices, which include imaging and other devices used for diagnostics in vivo. But they only have it, it's done in almost in silos, because they have 4 different documents for different categories of diseases. They don't have a comprehensive prioritized list for devices, and there is little, if any, linkage existing between the in vivo and the in vitro devices. So if you don't have a simple list that governments can readily identify recommended priorities by WHO, it makes their task more difficult. Also in the resolution, there are discussions of how to use market mechanisms to make diagnostics more affordable. I mean, I'm sure you're all familiar with the work of the Global Fund, which has used advanced market commitments, pooled procurement, etc., to help make key items like antiretrovirals more affordable. And it's been win-win. The manufacturers have sold more kits for malaria RDTs, and countries have been able to buy more kits for better prices and thereby, assist in the fight against malaria. And there are other similar examples. So South Africa apparently gets almost the best prices in the world on HIV diagnostics kits because they pool their procurement, through the public sector to get lower prices. PAHO has relatively successfully done pool procurement of diagnostics and other medical supplies, and they perhaps have been more proactive than other WHO regions in this. And in Africa, you have the experience where Africa CDC has undertaken full procurement of COVID-19 tests, to avoid the situation where countries bid against one another to get supplies. By doing pool procurement, it's easier to organize the market. And it's important in markets where there are very few suppliers. If you're many buyers trying to, deal with half a dozen suppliers, you're at the mercy of those suppliers. The resolution also calls on WHO to support national procurement efforts and for member states to prevent anti-competitive measures. And it also calls on collecting data on market shaping. And all of these are aimed to improve affordability of diagnostics. Okay, and then there are some overarching actions. Okay, I guess I'm doing these next 2 slides. So these may sound more boring. The first one, to develop an official definition of in vivo diagnostics. At the point at which Kingdom of Eswatini was writing the resolution, they ran into a roadblock. There is a definition of in vitro diagnostics that can be used. I think both FDA, the European Union, and WHO all had a definition of in vitro diagnostics, but there was no official definition in any of those areas of in vivo diagnostics. And in the resolution, I think they had to write in non-in vitro diagnostics, which sounds a very cumbersome way to describe it. So that sounds like a boring but essential task to get started. It also calls on the Director General to collect data on the affordability of diagnostics, because without that, you can't work on prioritization. You can't see where people are having the greatest difficulty in affording diagnostics that are absolutely essential to diagnose their health conditions. Okay, and it was a precursor to the work on affordability of medicines that they, I think it's called HTA, collected data on affordability of medicines, and then that monitored that over a period of time. And that's an important advocacy tool. Another action, WHO is committed to avoiding silos. As we mentioned, the in vitro diagnostics and the devices are within the same department in WHO, but the two sides don't talk to one another a whole lot. And also in WHO, it turns out, although they only have, I think it's 2 or 3 professionals in the medical devices and diagnostics unit, there are other professionals who are experts on diagnostics, but they are spread across the disease units within WHO. So, that doesn't lead to a lot of, advocacy and visibility. So avoiding silos is important. And at the same, and obviously, if these silos exist at WHO level, it's possible they exist in the member states also. So African Society for Laboratory Medicine, has high visibility, has been established a long time. There is a comparable organization, African Society for Radiology, but we had more difficulty in contacting them, in the course of writing the commission report. They do have meetings every couple of years. And I would also be interested to know if you, as professionals, have had links with the African Society for Radiology, or if within your own countries you make links to the radiologists and the imaging professionals. And the reason I say this is one thing that struck us when we started out the commission was that the general population only has a sort of vague idea what pathology and laboratory medicine are. It seems very technical. And also if you ask them what is radiology, again, people are somewhat confused. I mean, I, as a non-medical person, for years used to mix up radiology and radiotherapy. But the term diagnostics is a lot clearer. And to the extent that both the in vivo and the in vitro groups can get together in countries, they can have higher visibility. They obviously occupy a larger share of the government budget and therefore, potentially are more important in policy discussions. And the general public can get on board and understand why these are important. Okay, so since the resolution has been in process, as of January, it was passed by the executive board and developments have started to happen. So the World Health Organization is now developing a definition of in vivo diagnostics, is going to get the diagnostics experts from the different groups within WHO to meet regularly. And the same thing is occurring at the level of the manufacturers. There's more connection. We were very happy to see that all the professional associations in imaging, along with some of the manufacturer associations, joined together to provide a letter of support, a constituency letter that was entered into the record at the WHA in May. And it was interesting to us to note that one of the major pharmaceutical manufacturers, Roche, has now established a diagnostics division. So often the pharma sector has an interest in diagnostics because you need diagnostics to show what the demand is for pharmaceuticals and also for the safe use in treatment of, you have to have these companion diagnostics. So one of the obstacles in the past to doing things like market shaping has been there's been no clear association linking the manufacturers of devices, whether in vitro or in vivo, and likewise, on the purchaser side, no clear organization organizing the consumers together. I mean, there are people who advocate for cancer diagnostics or people who advocate for HIV diagnostics, but not necessarily diagnostics in general. Okay, so Ken.
Is this the last one, Sue?
No, there's this one and then the Alliance 3.
Okay, so this really just flags up the publicity that the resolution has been getting. It's surprising and gratifying in many ways that so much notice is being taken for this. I think it represents a terrific opportunity for us in the diagnostics arena to take advantage of this. We have probably only one relatively short period of time to have our time in the sun, and therefore we have to maximize and optimize the opportunities we get. Again, we are trying to publicize as much as possible and having a meeting with you today to try and get, as I said earlier, feedback on what your views about this are and how realistic and otherwise are some of these recommendations. So the next slide, Sue. One of the key continuing features of what the resolution has proposed and also the Commission is that this is a long-term problem. It's going to take 10, 20, 30 years to really solve. And so what we're proposing is that people need to get together. It's, as Sue said already, it's a vast area, very diverse. No one single group can really deal with this on its own. So I think it's very important for us all to try and work together as much as possible. So what we propose that there should be some sort of body, which is an International Diagnostics Alliance, something of an umbrella organization. I've indicated here on the right the sort of individuals and organizations that might be part of any such alliance. It used to be very diverse, and its roles are indicated, some of them at least on the left-hand side here, primarily looking at implementation of the recommendations. And they can use a variety of tools to do this, convening specific working groups, exchanging ideas, and so on. Collecting data on progress is going to be very important to see where things are improving and where things are not improving. And lastly, continuing advocacy is going to be really important. And the Africa CDC has been very involved in helping to think about the alliance, as is indicated here. The preliminary discussions have been taking place for the last, I guess, maybe 6 months now, involving ourselves, the Lancet Commission, that is, FIND based in Geneva, and CHI, the Clinton Health Access Initiative, and the African CDC. We've been looking and talking together about how best to set up the alliance and what it might do. The idea is over the next few months, between now and perhaps the end of the year, we'll consult with a very wide range of potential stakeholders, including ASLM, for instance, and discuss what the aims, objectives, and how the governance model should be. And eventually, out of that widespread discussion, come to some proposals. And hopefully, with a bit of luck, next slide, Sue. These are just some of my personal thoughts, by the way, on what the aims and the governance might be look like. My personal view is the aim should be equitable access to safe, affordable, quality-assured diagnostics with a focus on primary care. That should be our #1 priority. A key component is that leadership and governance has to come from the countries where the unmet needs are the greatest. This is really important. This cannot be top-down. It has to come from countries, and it has to be from the countries who are dealing with the problems, most difficult problems. It's got to be transparent decision-making, obviously. Again, a key issue I'm very concerned about is that existing mechanisms we have in place in countries are used, and we don't build systems alongside them or separate from them. This is going down to the second last bullet point, I'm concerned about the pandemic preparedness proposals, building networks for molecular diagnostics, for instance, of infections. It really should be part of the pre-existing system rather than a new, completely separate system. And then just touching on the last point here, in vitro and in vitro diagnostics. And hopefully we want to have this governance and this alliance launched within about a year, ideally next WHA in 2024. Next slide, Sue. I think that's the final slide, and it's really just a photograph here from a discussion we had in Geneva at WHA week when the resolution was being discussed and passed. And the lady who's on the second from the right beside me is in fact Philomena, who's from Eswatini, who was the main proponent and driver of the resolution, and she deserves a huge amount of credit how she took this on and made it happen. So I'm going to finish at this point. Sue and I are really interested to get feedback and get any questions and do our best to answer them. So thanks very much.
Great. Thank you both for the wonderful presentation and outlining the key important steps that need to happen, and a lot of credit, as you say, to the Kingdom of Eswatini and the rest of the nations are involved to make sure that this resolution is passed. And as you mentioned, a resolution starts as a paper. But what is it that we can do to make sure that it moves from paper to actual action? And all is to do with making sure that diagnostics are accessible, and that means affordable to everyone, including that last mile, as you have put it. So there are a few questions in the chat that are coming through, and I know you have mentioned quite a lot that WHO needs to do, and the question also is what the countries have to do. So let me try and see if I can pull out a couple of them from the chat here. Let me start with this one. Francis says, are they aware that there is a significant reliance on donor funding for a good number of countries? Is it inevitable that the pace at which some of these resolution areas are currently not prioritized for funding, including the R&D that you have mentioned, and this will depend on how fast funding agents adjust their priorities? So there's a role for funding agencies here. There's a role of what countries can do. Maybe we can start there to comment.
Okay, maybe I could just sorry.
I was going to say, as the economist, I'll perhaps start on
okay.
Financing.
Go ahead.
So yeah, absolutely. And I would say the following, that the global health community has typically committed to funding with priority for infectious diseases, but they have tended to regard the non-communicable diseases more as a domestic concern. So, that's how it's been done in the past. I mean, we became aware in the course of preparing a webinar in advance of the discussion of the resolution, of the Right Foundation in Korea, which does help funding for new diagnostics and for low and middle income countries. So if you're not already familiar with the Right Foundation, RIGHT, you might look into that. And obviously you're aware of the activities of FIND and of CHAI in trying to develop affordable and appropriate technologies for diagnostics. Ken, did you have additional thoughts?
No, just I was going to say I was at a meeting in Geneva at WHA, which was had the chief exec of the Global Fund, and I was really pleased to hear him talk about how important diagnostics is, and I think to some extent he was rather surprised about the extent of the interest and the recognition that this was key to universal health coverage, and so. going back to the question about funders, I think funders are starting to recognize, and I think this is really the fundamental problem. It just diagnostics, for a variety of reasons, probably has been invisible to those who allocate resources. And as I say, we've mentioned already, is COVID has been a fantastic wake-up call. And we really need to take use of that opportunity to governments and other funders to say, this is only one example, and we need to make sure that we've got a broad-based diagnostic system, and we need the funding to do that. So it's a very complicated, difficult problem, but yes, funding's crucial, of course, but we have a chance. We've caught attention. The resolution has got political notice, and it's now down to us now, I think, as the professionals and the people involved in diagnostics, to make best use of it and how best to do that.
Thanks a lot, Ken. I think picking up from what you are saying, I think indeed, I think we have that opportunity. Sometimes that window can be small. There is a lot of attention now on diagnostics, and the examples that you gave really underscore that. And before we move to the next area, I still want to hang on that bit of funding. Can we be able to ride on this attention? There is the Abuja Declaration, which calls for governments to actually put a certain percentage, 15%. Could this be the moment where we could actually try to ride on that attention on diagnostics to make sure that at least there is that domestic funding that comes through? I know you mentioned that many of the funders are going to the infectious diseases, but the non-communicable diseases has been left as a sort of domestic challenge. What are your thoughts on that?
I'll just chip in quickly. Currently, most countries spend between 2 and 5% of their health budget on diagnostics, which is a pretty small component when you consider 70% approximately of clinical decisions are based on the results of diagnostics. So I think, in a way, we've been almost our own worst enemies. We have not made the case loudly enough that for a relatively modest, very modest part of the overall budget, you get a huge impact. Some of the work that Sue and colleagues did in the commission was on looking at the cost-benefit relationship of certain tests. And virtually 5 out of 6 of the tests we looked at, the cost benefit was positive and sometimes very strongly positive. It's an investment which pays off. So I think we just have got to try and make use of the opportunity of our time in the sunshine to make the case as best we can. And it really is incumbent on all of us, including people in each country, to try and make the case, say to your governments and to other people, look, this is important. There are ways of doing this. It's a good investment. And we've got plans of how best to do it. And I'll hand over to Sue.
Yeah, I think we do have to be cognizant these are really challenging times. They're challenging times internationally because, with humanitarian crises and conflicts existing, which have also disrupted food production and food supplies and food prices. So not only are the international organizations finding it challenging to divert additional funding, but national governments also face issues. I mean, in addition to the things I've mentioned above, many countries, including those in sub-Saharan Africa, have sizable debt repayments. Did I read somewhere that something like 15% of their international commitments now have to go to debt repayments on average, and some countries are much more exposed to that. So I think, early on in the commission, we looked at the Global Fund and Gavi, the Vaccine Alliance, as these, well-funded international organizations, for treatment and diagnosis for specific diseases and for vaccines to prevent. And there have been calls in the past for a similar alliance for diagnostics. I think the alliance will be extremely important, but I don't think it's going to look like Gavi and the Global Fund. I think there are so many competing priorities that putting a large amount of funding into a diagnostics alliance is going to be challenging at these times. But as Ken said, we also at the same time have to advocate Thanks, Anafi.
Thanks, Sue. Moving on to the next line of questions. Moving to country level, who do you envision to be the owner of the strategy where we are bringing the in vivo and in vitro diagnostics at a country level? Would that be the mandate of the MOH to move this forward? Diagnostic programs? And I think I want to join that with the same comment that you made, that at WHO there is also silos within the medical devices section, and the one that is also doing the NEDL.
Maybe I'll just pick it up first, actually. I mean, yes, it seems to me it must be national governments take at least provisional or at least initial ownership. If we don't have the support of the politicians, nothing much is going to happen. We can have people doing their best and making some efforts, but if the governments and the Ministry of Health, and actually the Ministry of Education, because education of workforce is a key issue, don't see the need to do this, and we're not going to make progress. So I think it's really important that nationally people do make the case as strongly as possible, building on the information that the resolution and the commission has provided. I mean, one of the things I've been thinking about for the International Alliance on Diagnostics is that we might have some sort of local chapters or regional type alliances where people in countries or groups of countries can get together and make the case locally for their own particular audience. So,
yes, I mean, obviously it's the Minister of Health is the key actor here, but everyone knows that it's the Ministry of Finance that is also key to have on side and to make the case to them. So that's why economists like me get brought in to try and help advocate. And at the national level, I think it's not, you can't just rely on the Ministry of Health. This has to be also a bottom-up movement. So you as laboratory professionals can help advocate, but ideally can also reach out to other groups who are aligned with you in your views as to the importance of diagnostics. So that might involve talking to people in the in vivo area, the radiologists. It involves making the clinicians aware of the need for better diagnostics. You know, the clinicians have been used to treating without having the tools to do a proper diagnosis because the money has not been there. But you know, the more that they are educated of why better diagnostics will make their job better and lead to better health, that's important. And then another really important group to involve is the patients and their advocates. So as you know, the cancer survivors have been, you know, quite active. Diagnostics are hugely important in addressing cancer early on to have the chance of, you know, survival. So in the course of doing the commission, we talked to, I think it's called Ian Kanda, and I've forgotten, the West African NCD Alliance. So talking to those groups and involving them is important. So, you know, you as professionals also have the opportunity to come out of your silos to work with these other groups, because obviously people who vote are important for the politicians who are deciding funding strategies nationally. Thanks.
Thanks. I think the message is clear. Whilst the MOH has to take lead, I think a multi-stakeholder approach is key, and that involves so many groups for that advocacy to be powerful. I'd like to move on to another question or theme here that comes through, and it also comes from your findings in the commission: workforce. And I pick on Daniel's question here, or maybe it's a comment where he is saying, can a well-streamlined training for laboratory courses for institutions that are, can we well streamline, I think, training for laboratory training at institutions so that it is standardized to meet the needs of the current day jobs and recruitment by employers. I think he is picking one key important part of this. We cannot get that full access to diagnostics without the requisite personnel. Yeah, maybe you can comment on that.
Maybe I'll pick it up just initially. Absolutely, that we need to have a workforce capable to actually do the work, as it were. It's interesting to me that why each country tries to build its own training programs. In fact, even each university in many countries are designing their own training programs. And this seems to me one area where we could absolutely learn from each other and have a relatively standardized program for training of technicians and scientists and so on. That a lot of what they do is the same between departments, between institutions, and between different countries. And therefore, there must be a sort of core program which we could all learn from and use. Other thing I would say is, again, even at training the medical laboratory workforce, again, I think some sort of work task shifting is going to be really important, because, again, the numbers are so large. I don't think we can just keep trying to turn the wheel faster and faster of what we currently do. I think we have to probably look at shorter courses which are designed to train for very specific tasks and that are properly both trained and supervised. So I think not only does the normal program need to be standardized, but I think we also have to look at different ways of doing it.
And just to add one thing, so the rapid advances in technology are making things easier, potentially more available at more far-flung locations, but it also requires training of the workforce. So not just new entrants to the workforce, but existing people have to continually upgrade their competencies to take advantage of these changes in technology. Thank you.
Yeah, I like the comment that you both are making, that we have to find different ways of doing this, and we all appreciate that we have been doing training for a long time. But why isn't there any change coming through? So I think we need to relook at how we are getting this, and I like the fact that you are saying maybe we need to go into those specific competencies, like you have given an example, and make sure we hone them, I think, one by one. Hopefully we get there. And one of the things that I think we are seeing with the laboratory profession is, when we are all doing this, do we find ways of recognizing that also, even in terms of their career prospects? Hopefully maybe that could change to make sure that we retain many of these. I want to also...
And Afi, can I just add to that? I mean, COVID was really interesting. But who would have thought millions of people every day at home were testing themselves? The children were testing themselves. You had 8-year-olds, 10-year-olds doing the tests, and what they were doing depended on that result. So I think one of the things, again, I'm going to say is that we're not going to fill this gap by doing more of the same. Yeah. And definitely point of care testing and pushing it out into the home, pushing it out into the community is going to be key. And the technology is getting better and better at this. And our training programs have to reflect that. So it's reinforcing Sue's point about, we have to have programs which allow people to adapt to the future, and perhaps even have recurrent training every, hand waving here, but let's say every 5 or 10 years to reflect changing needs. So I think actually diagnostics are going to change quite a lot in the next 10, 15 years, and how it's done. And our training programs will need to reflect that.
Yeah. And let me give a shout out to ASLM, because you have been proactive in these areas. For example, the SLIPTER and SLIMTER. I know you've been working to get common standards and to help people reach them. And, in the area of workforce and training, I think you also have an important role to play.
Yeah, indeed. Like you're saying, the half-life of technology is just like mobile phones is very short. And I'm hoping that one of these future sessions, we could actually talk about the future of diagnostics. How would that look like? So interesting discussion. We also talked about, and I think I want to pick from your comment that many of the clinicians maybe probably don't have enough support in terms of treating patients without enough diagnostics. One would equate that to saying we are flying blind, probably because there is not enough access. And one of the solutions that has been mentioned there is, can we do something around regulation? And I'm picking this on Stanley Nkema-Kolam, I hope I pronounced this correctly, where he is saying, how is it possible to develop a common regulatory framework towards development of diagnostics for consumption worldwide to allow for affordability? Is that even possible? Or maybe we need to be going to regional. How do you see this happening in terms of harmonizing diagnostics at regional and maybe sub-regional level?
Yeah, maybe I'll just quickly say my view would certainly be it's regional. I think to talk about having something even at a global level is unrealistic. Everybody's different. The countries are different. The contexts are different. But I think you can have regional harmonization. So, for instance, I was quite involved in setting up COPEXA, the College of East, Central and Southern Pathology in Africa, College of Pathology of East, Central and Southern Africa. And one of the reasons for doing that college over that large region was to try and develop, for instance, regional exams, recognition of training programs and so on. So regionalization and harmonization of regulation across regions can actually work. And as I say, COPEX is a good example in Africa. So you've done a bit on regulation.
Yeah, so I mean, in Africa, obviously you have some very big countries, but there are also close to 50 countries. And so hence doing things at the regional level is potentially very valuable, especially because the countries have some similar characteristics in terms of key diseases that are important in sub-Saharan Africa that are not important in Europe, for example. So I think regional is important, although I appreciate it's slow and bureaucratic. I mean, the EU spends hours in bureaucracy to try and get common agreement on issues across those countries. And the other way things can occur, I mean, is, for example, we know that about pre-qualification processes at WHO, and also UNICEF has products that they single products or single types of products that they have approved as safe and effective. And so, there can be also this top-down, but at the same time, WHO does not move at the speed of light, and we can't rely on them.
Yeah, interesting. So I think that's maybe one way to go. We could be thinking of those regional pre-qualified lists to kind of speed up maybe uptake at regional level. They say all good things come to an end. We are almost 1 minute before time, but I wouldn't have done justice if I don't take this question that just caught my eye. Over the past few months, I think the area of artificial intelligence has just taken center stage. And I just want to pose that to you. I think Kenneth Maeka here is saying, what are the prospects of seeing artificial intelligence and machine learning taking center stage in diagnostics in the near future? Could it one of the answers?
I'm just going to answer this. I think absolutely. I'm actually doing some work on developing artificial intelligence for interpretations of histopathology slides with a company here. And I am gobsmacked about how the technology is developing. And I don't think there's any doubt that it's going to make a huge impact, not just in interpretation of images, but in supporting people. So I think it is definitely going to be how that's going to work out, we shall see. But the short answer is yes, it's going to make a big impact and will actually help to solve some of the problems.
Great. Thank you very much, Prof. In the last 1 minute. Can I give Prof. Su 30 seconds to give any last few remarks?
That's a tough thing to do. It's been a great session. I see that there are more than 220 participants, which is fantastic. And I think it's great that you are doing these sessions regularly. I think that will really help move things forward in Africa. And just to say, we forgot to include our email, but in the PowerPoint. But if you'd like to communicate with us further, you can email Diagnostics Commission, don't forget the S, @gmail.com. And we'd love to hear from you and get your feedback. And thank you so much for your input.
And Afi, can I just, what I really wanted to say is the opportunity is here and now, and the opportunity is in our hands. And we, the profession and the users of the diagnostics, have got to now make that case. And I think one of the problems in the past has been too passive about this. So I really urge, it's now our responsibility. Let's seize the day and seize the opportunity, and make the case for, in the long run, for the benefits of our patients.
Thanks a lot, Prof. Ken and Prof. Su. It's been an honor for us to have you here on our session. Very interesting discussions indeed. We have not managed to even exhaust many of the questions that came through the chat, but as usual, we'll go into the chat and maybe share with you some of those questions that we have not managed to do so. I think this discussion just took out a lot of key things that we need to discuss, and a lot of it is around diagnostics for the future. And I'm hoping we could actually regroup again and see one other platform where we could actually be discussing this. Thank you very much for joining here. And I see a lot of people from all 4 corners of the world. So again, good morning, good afternoon, and a very good evening.